Chronic heart failure is characterized by decreased stroke volume and cardiac output due to abnormal systolic function. This leads to activation of the sympathetic nervous system and renin-angiotensin-aldosterone system. From this, we observe vasoconstriction due to increased sympathetic tone and impaired nitric oxide release. We can also see sodium and water reabsorption due to vasopressin and aldosterone. This places further stress on the heart, causing remodeling, which results in worsening function and further decline. Additionally, patients experience decreased response to natriuretic peptides due to downregulation of receptors, increased clearance by neprilysin, decreased signaling, and decreased activation. Treatment for systolic heart failure includes ACE inhibitors, AT1 receptor antagonists, beta blockers, diuretics, aldosterone antagonists, vasodilators, digoxin, and ivabradine.
Last year, the TGA approved Sacubitril-Valsartan for the treatment of systolic heart failure. This consists of the new neprilysin inhibitor sacubitril. Sacubitril is metabolized by enzymatic cleavage to its active metabolite sacubitril-8, which inhibits neprilysin. Neprilysin is the enzyme responsible for degradation of vasoactive peptides, including bradykinin and substance P, as well as natriuretic peptides, including atrial, brain, and C-type natriuretic peptides. Natriuretic peptide receptors are coupled to guanylyl cyclase, which increases intracellular concentrations of cyclic GMP. This then activates protein kinase G to exert biological actions, resulting in overall reduction in blood pressure and volume. This includes inhibition of renin and aldosterone to promote natriuresis and diuresis. By blocking the angiotensin receptor without directly inhibiting ACE, the combination treatment has a lower risk of angioedema compared to previous developments such as omapatrolat. This is due to reduced bradykinin accumulation. Although sacubitril has a different mechanism of action compared to the gold standard treatments, ACE inhibitors and ARBs, its ultimate effects on the renin-angiotensin-aldosterone system and the heart are very similar.
In order to critically appraise the available evidence for the use of sacubitril in the management of heart failure, we reviewed 5 well-known clinical trials, and we assessed areas such as clinical trial design, randomization and bias, inclusions and exclusions, patient sample size, clinical trial length, and limitations. The first 3 trials that we assessed were IMPRESS, Overture, and Octave, and they included the combination of neprilysin inhibitor alongside an ACE inhibitor. However, this combination shortly got taken down due to the increased risk of angioedema with its use. However, these 3 trials were of low credibility due to patients being unaccounted for, results not being tabulated, and adverse effects not being noted. Furthermore, the next 2 trials that we assessed were Paramount and Paradigm. Now, these 2 trials assessed sacubitril alongside valsartan, an AT1 receptor antagonist. And these 2 trials were of higher credibility due to all patients being accounted for, adverse effects being noted, and results being tabulated efficiently. As you can see, there's a decreased risk of mortality with the use of sacubitril in all 5 clinical trials. Also, adverse effects that were noted in Paramount and Paradigm did not compromise therapy and were non-critical. However, there is still plenty of limitations that pertain to the use of sacubitril in the management of heart failure. Now, the biggest limitation is that 83% of the patients that were assessed were of white ethnicity. Furthermore, 75% of the patients that were assessed were of New York Heart Association classification 2 and 3. This therefore excludes patients initially hospitalized for heart failure and patients who underwent end-stage heart failure. It also excludes patients of other ethnicities. Other limitations pertaining to the use is that there's no measurement of the sustainability of sacubitril's effects in the management of heart failure, with the longest clinical trial length being 27 months. Another limitation is that there's no clinical trial to date measuring the monotherapy of sacubitril in the management of heart failure. It's always combined with an ACE inhibitor or an AT1 receptor antagonist. This therefore excludes patients who are unable to tolerate these 2 therapies, including Black patients who report more angioedema with its use. So overall, we see a clear effectiveness and decreased risk of mortality with the use of sacubitril in the management of heart failure. However, there is still a lot of limitations that pertain to its use, and in future, we should see clinical trials that measure the true effectiveness of sacubitril in a real-world setting.